Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining the Weekend Educational Series. Today, Dr. Lynn will discuss reducing bias in child abuse and neglect evaluations. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. After reporting your attendance, you should log into your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. Now we will proceed with today's presentation.
Thank you, Elizabeth, and welcome everyone. Thank you for attending today. I'm going to be talking about reducing the impact of bias in child abuse and neglect evaluation. I have no conflicts of interest or financial affiliations that need to be disclosed. I'm going to ask that I think by the end of today's lecture that you will be able to describe at least 3 types of cognitive biases and cognitive errors that can result from those biases, and that you will have 2 individual and 2 systemic strategies to mitigate against the impact of those cognitive biases on your decision making. The webinar is broken into 2 different categories. The first part, we're going to be talking about what are cognitive biases and some examples of those, followed by some strategies to prevent the impact of those cognitive biases on making the very best decisions. So we're all human on this call, and every day we're dealing with people, and people, by the very nature of how we're hardwired, we have biases that potentially could impact every decision and every thought. We know that reports to authorities when there is no maltreatment is harmful to families. And I don't know why that just went to that mode, but is harmful to families and it wastes resources. So I think everybody probably on this call is very focused on making accurate identifications of child maltreatment as much as possible. But I think at the end, we'll talk a little bit, we have to accept that sometimes there is a gray zone, there's ambiguity that we have to learn how to deal with. 4 to 8 children die every day from child abuse and neglect. We know it's underreported and underdetected. By far the majority of child abuse and neglect victims who die are under the age of 3, and 50% of them are under 12 months of age. They're infants. Missed maltreatment is very common, and previous reports for concerns of maltreatment are very predictive of children who are at risk of dying in the future from child abuse and neglect. Confirmed child abuse and neglect, you can try to put a cost on it. Several people have. You see one number here. That's from the FANG article that's referenced on this slide. $124 billion each year, lifetime costs that's for confirmed child abuse and neglect. But I don't know that we know the cost or could even reasonably estimate the cost of missed child abuse. And then, of course, there are costs associated with inaccurate diagnosis of child abuse. And again, that would be hard to estimate. Multiple settings are where these victims of child abuse show up. They can be, some of them never present for medical care at all. My goal today is to hopefully sensitize you to some of your own individual biases and give you some practical strategies for mitigating against those. We know from experience that emergency departments and urgent cares and primary care settings are a common place where child maltreatment is missed. And if you think about that, that's not surprising. The majority of children coming into pediatric clinical settings have not been abused. And in the ED setting, only about 2% of all of those visits are due to something related to abuse. So if it's not on your radar, you're at risk of missing it. And by this very fact that it's only 2% of kids in the ED, we're at risk of missing it. Carol Jenny published a very important seminal article back in 1999 that looked at how often abusive head trauma is missed when it first presents for medical care. And one can argue with the study design, but I think her point is well-founded and has been repeated in multiple scientific studies published to date. And that is, in her study, 31% of abusive head trauma, what we used to call shaken baby syndrome, is missed at first presentation. We know abusive fractures are often missed. One study showed 21% were missed. And then in the study that we performed at the Medical College in Children, 42% of abused infants had a previous injury from abuse that was known to a medical provider, yet the child wasn't protected and went on to be further harmed. So why is maltreatment missed? And that's the focus of today. Bias plays a major role, and research has shown that cases involving white families or two-parent homes, or I need to move over a GoToWebinar panel because it's actually blocking my view of my slide. But we know that non-pediatric emergency departments are at higher risk. Abuse is not even considered in the differential diagnosis of injury sometimes, and even creating ways to make sure that people are at least considering it in the differential diagnosis, which is what that DDX stands for. When it is suspected, we know that screening for occult or hidden injuries needs to be performed routinely in children under the age of 2 when physical abuse is a concern, because we know that those can't be picked up on physical exam alone. We call those occult injuries. And then we know that just human nature is to want to explain away abuse, because it is really hard to think about another human being intentionally harming any child, but let alone an infant or a young child. And so often medical providers and others will offer de novo history that's not even being provided by the family, such as the injury was self-inflicted or somehow occurred because of some benign care practice, which is not expected to result in injury. Abuse is less common, and I referred to that in the emergency department. When it's only 2%, it makes it hard for that potential diagnosis to stay front and center in certain cases. And so what we see, and this was term borrowed by Dick Krugman and John Leventhal in this article that I've referenced at the bottom of the slide, is we have this human tendency, which is totally understandable for gaze aversion when it's possible child abuse, is that we want it to be anything but child abuse. And I think most child abuse pediatricians who I know prefer it to be anything but child abuse. So we're all at risk of this bias, if you will. And then we have this, I call it ABA or anything but abuse bias, but if abuse must be considered, it means that our day is going to look very different. It means there's going to be a lot more work up front, and for many of us, a lot more work after the fact, because abuse was a consideration. So we have a essentially a built-in disincentive for medical, police, child welfare professionals, and really all, I think, many systems, that life is easier and more simple if there's clarity, but also if it's not abused. So this leads us to errors in thinking, or cognitive errors, and those are due to what I'm going to call are all cognitive biases. But it's this group, or this trio that you see here. I apologize for pop-ups on my screen. You see here a failure of heuristics, and heuristics, it's a fancy term for something that all of us know, and those are kind of our mental shortcuts. And that's what allows you to get through your day without thinking about every time you put your foot, are you putting it in the right place? I apologize for some technical challenges here. You know, where is my hand? How do I dial the phone? Those kinds of things. Those are, we don't even have to think about them because we do them all the time. And those are involved in decision making in medicine, but they're also involved in really almost all decision making. We have certain mental shortcuts. We also sometimes have failed perceptions, and so checking our perceptions with others can be a helpful strategy we'll talk about more later. And then all of us, by the nature of being human, we have biases. So the result sometimes, and not always by any means, in fact, I think not often, but sometimes, is that we have decisions or diagnoses that can be flawed or inaccurate. So what are biases defined? It's basically a tendency, and it can be, people talk about implicit bias a lot, or unconscious bias, but many times at play, there can be very explicit bias that's also at work. But it's a tendency to prefer one thing over another that prevents you from being objective and that influences understanding or outcomes. Bias implies an unreasoned or an unfair distortion of judgment in favor or against a person or a thing. As I mentioned, to be human is to have biases. And if you're interested, or if you think that you don't have implicit biases, I would encourage you to go to this website that is in your handout. They have a very interesting self-test, self-assessment about implicit bias. So we have these cognitive biases that we're going to dive in a little bit deeper today. And just so people know, I will be watching the question pane, but I do have some question breaks in here, so I'll be attending to those at those breaks. So we're talking about cognitive biases today, and that's we've kind of defined that for you, but keep in mind that there are always at play these internal factors and external factors. And when this diagram initially was in my slide, I did not have these arrows, but a wise colleague pointed that out to me. And there is an interplay between our biases and both these external factors and internal factors. And so those got added, but many times good decisions can result from cognitive thinking, critical thinking, especially with checks and balances in place. But in a busy ED setting or a busy clinic setting, and I can just imagine in a understaffed law enforcement or child welfare setting, we're all at risk of these internal factors such as stress and what our knowledge base is. I think we've all dealt with people who have been overconfident. Sometimes there's the physical exhaustion. I'll point out COVID that I think is leading to some mental and physical exhaustion for many of us. There are also these external factors. It can be the end of the shift. You're thinking about your plans for this evening, and all of a sudden a case comes in that's going to be time consuming if we identify it as concerning for abuse. There are time constraints. Your supervisor may have their own biases, and you feel that kind of that overlay in your decision making. Sometimes we just don't have enough information, but we may not realize it. And then I think, at least in medicine, there's been a lot of attention given to this, is that historically there's been a very perceived hierarchy and an actual hierarchy that sometimes gets in the way of people speaking up when they see an error about to occur. So cognitive biases can affect all of our systems. Its impact really can impact the case throughout the life of the case and even before a case becomes a case. So those can be examples like a medical provider failing to even think about abuse or failing to report. And the flip side of that is somebody following into a profile that they see as a high risk for abuse and maybe over-reporting. On the child welfare side, it could be a failure to screen in a suspected abuse, or screening in on the basis of maybe systemic pressures that systems developed in the context of humans. And so sometimes biases actually became incorporated in systems that are supposed to serve people that may not serve them in the best way because of those systemic biases. In law enforcement, it can be a failure to investigate, or maybe an investigation that's based on bias. So there are many types of these, and I'm going to talk about some examples and some of the most common examples that we see play out in child maltreatment. The challenge is bias, and we all have a gut feeling or an intuition that we're hardwired that way. We all have our midbrains with feelings and intuition and our heuristics of quick decision making based upon things that we may not even fully understand. And so these intuition, gut feelings are sometimes referred to as system one thinking versus more of our critical cognitive selves, where we're up in our brains and critically thinking about our decisions, and that's system two. And unfortunately, system one can sometimes inadvertently guide decisions, such as our impression of a family being nice, or they're articulate, and quickly disregarding whether abuse could be at play or neglect at play. We certainly see that in well-resourced families and perceptions of nice families. We know from research that the poor and sometimes people of color are at increased risk of over-screening and over-reporting. So you take all of this, you take, the collective systems that are all working collaboratively together to hopefully accurately identify child maltreatment and work in a collaborative way. But we all come with these cognitive biases and external and internal factors. And we have a common goal, and that is to make accurate identification of child maltreatment and hopefully find safety for children and hold perpetrators accountable when child abuse has occurred. But this mixture can also lead to mistaken allegations of child abuse and neglect, but also missed child abuse and neglect. And there's damage and harm with both of those choices. So some common landmines that I see frequently, I've mentioned a few of them already, is that our human nature, I think in general, I think most of us, including myself, believe that people are good for the most part. And it's hard to think of a good person doing something bad, particularly hurting a child. And so you have that human nature that that drives you toward that gaze aversion. We also have this inherent bias that I've mentioned, this ABA, and I don't mean to offend any attorneys who are on the webinar, but it is a natural bias that our days, our work are much easier if it's not abuse. I can tell you our team likes to find cases that are mimics And sometimes uh, we often will look hard, long and hard for those because those are easier for our team, but also often treatable for the child. And I think finding safety for children can sometimes be challenging. And I don't envy the role of our child welfare professionals because some of that's very difficult, particularly when there's ambiguity. If you're aware of your own biases, then you need to be challenging their influence on your thinking. And I think all of us go to that, it's a nice family, or the family looks like me or seems like me. And then those biases can be at play. And then I think the human mind has a way of filling in gaps. And I think all of us, if we use our critical thinking, should actively avoid this and help each other avoid this. So our team will sometimes be told that an unusual series of events led to injury. And because of all of these biases at play, the people who are normally good critical thinkers will kind of fill in those gaps and kind of say, well, I could see how that could happen, while completely disregarding kind of that critical thinking, what injury is expected, does this really make sense, and ignoring the evidence, the science that's well published and well conducted research. This can result into cognitive errors, and we see this premature closure play out in multiple settings, including medicine, child welfare, and law enforcement. An example in medicine is that kind of that perception of a family being nice, therefore we're just not going to screen for additional injury, and that leads to premature closure of a case that may be child abuse. We also see people drawing inappropriate conclusions from some testing, such as, they do a single skeletal survey on a young infant with injuries concerning for abuse. And because that single skeletal survey doesn't have injury, they feel like they've ruled out abuse, which is not the case at all. We see many abused children who have completely normal skeletal surveys. It just means that that bony injury may not have happened or may not be detectable on that first skeletal survey. So child welfare, this plays out there. It's that reaching a conclusion, it's just a bruise, leading to premature closure, or the family is nice, presents well, home visit, the house is clean, everything seems to be in order. We've seen cases screened out or closed, I shouldn't say screened out, but closed prematurely in those cases. And then when resources are short, I think law enforcement sometimes will do this because they may do an initial look at a case, and because certain elements, for example, a child who has burn injuries, and the provider or the caregiver says that it was caused by an accidental contact with a curling iron, and they may go to the scene and find the curling iron, and they may everything seems to be in order, prematurely close the case and sign it out as sick and injured, ignoring the fact that the curling iron injuries don't fit a pattern of accidental injury. So I am not meaning any one profession. I think all professions are at risk of these cognitive biases. Looking at the question pane and seeing no questions, I'm going to move on. So ways that that cognitive bias can play out, I'm going to quickly go through some of these, but the examples I do think help. So that initial failure to even consider child abuse is something that we saw in the sentinel injury study in some of those cases of missed abuse. The perception that the family was nice, I think family medicine, but also pediatricians struggle with this because they've known families for a long time. And when you're face to face with somebody you've known for a long time and may even know outside of work, I think it can be really, really hard to consider abuse. We are impacted by mental shortcuts at work, in a high volume setting like an emergency department or an urgent care clinic. We can sometimes take injuries that are equivocal. So say a clavicle fracture, or that's the collarbone, or a parietal skull fracture, that's the side of the head. We see those as accidental injuries sometimes, but we also see those as from abuse. And whether that is even on the provider's mind or not is sometimes an issue. And then language sometimes can get in the way. A toddler's fracture is, by definition, it's an accidental fracture. And it's commonly seen in kids who are early walkers. It's a non-displaced spiral fracture, usually of the tibia, which is your shin bone. But when we see the term toddler fracture used in a baby who's not yet even walking or is just barely starting to bear weight, it's an unfortunate combination of terminology and facts. And that is, a toddler's fracture puts most medical providers into the mindset that this is accidental, we're going to treat it, and abuse may not even be considered. I'll show you a case in a few minutes where that had very devastating results. And sometimes when an injury is medically trivial, I think it can be really hard for people to think about abuse and do a workup and make reports. And sentinel injuries are the reason that term was chosen, was to help people get out of that thinking that can really put an infant at risk. So sometimes the provider may consider abuse. If they consider it, that's great, but they may dismiss the concern prematurely, that premature closure. And I've already mentioned the nice family kind of bias. But what can happen is that the provider may know, if they're up in their critical thinking, their cognitive self, and checking their reasoning with their colleagues, they know that this injury doesn't usually happen that way. But then there are all sorts of other pressures then that can come at play. It may be a person that they know, it may be the end of the shift, it's a busy clinic, it's that ABA bias, it's a wish to believe the goodness of people. And I think you can have good people who make bad decisions. And that sometimes is really hard for people to consider, that this could be abuse, but yet the person you're looking at, who you know is a good person, still could have done this. And I think all of us are challenged with this. We know that language can play a really important role here in helping us think more critically. I've given you a couple of examples, the toddler fracture being one, bruise being another. Another is a nursemaid's elbow. If you've never heard of that, it's a subluxation or a dislocation of the radial head at the elbow. So one of the forearm bones slips out of its normal position, gets dislocated, and it's really a common accidental injury in walking children. Less commonly, though, it is not expected in pre-cruising infants. But if we call it a nursemaid's elbow, and this is played out in multiple medical settings that I've seen over my career, if you call it a nursemaid's elbow is easily treated. And I can tell you it's kind of fun to treat because you fix it just by a manipulation of the arm. And so if you call it a nursemaid's elbow, you already have maybe a med student, a resident, or an attending quickly trying to fix it, and sometimes doing so without critically thinking about, this is not expected in a 4-month-old infant. So it's that critical thinking part of our brain, that system 2 thinking, that we need to really keep front and center and build in checks and balances that keep us on track. Sentinel injuries, you've probably heard me talk about them many times. I think the awareness within our field of sentinel injuries, before they were called sentinel injuries, the credit really goes to Naomi Sugar and that pediatric group in the Northwest. She did a really important study, and if you haven't seen it, I'd encourage you to look at it. But she coined this phrase, and it's been, you'll see people talk about variations of the phrase, but basically those who don't cruise rarely bruise, or if you're not cruising, you shouldn't be bruising. And years then ensue after that, and we're still missing infants who have unexpected bruises. And so the main driver in doing the sentinel injury research was that we need to better understand these pre-cruising infants with bruises and start at least increasing the awareness that some of them, if not many of them, are due to abuse, and sometimes they're due to a bleeding disorder. And so the language, the terminology sentinel injury was particularly coined to try to get people back up into their system 2 thinking and avoid these devastating cognitive errors. Remember, sentinel injuries, most people think of them as just something that you might see on exam, or that you might see on a home visit, or you might see in a police investigation. But remember, you can ask about them, because in general, caregivers, and often mothers, if you ask a mother of a 6-month-old, have you ever seen a bruise on your infant? And then ask her to describe what she saw, how long it lasts, what it looked like, you can elicit sentinel injuries by taking a careful medical history, but also just asking some very basic questions. And then these need further investigation. It's not that all of these are from abuse by any means, but further investigation, further medical care is warranted in these cases. The other, I think, culture of medicine that, particularly around child abuse and neglect, that has caused some confusion is most medical providers think about diagnosis, differential diagnosis. What is my first diagnosis? How am I going to rule out other possible diagnoses that could harm this patient? And then how do I treat it? But in child abuse pediatrics and in medicine in general, we're mandatory reporters. And so people struggle with this, because what it means is that we are asking medical providers who don't normally live in this world to essentially consider abuse and make reports to law enforcement and or CPS when there's reasonable suspicion of maltreatment. And I think this confusion for medical providers causes a lot of angst, but also results in people sometimes waiting until they're at the diagnostic threshold before they make reports. So back to the language, and I apologize, you're going to hear a dog, my dog in the background. But putting too much weight on initial impressions of families. And so this was an anchoring. A lot of these have names, and you can go and look at Pat Crosscarry's work, which I reference at the end. But you can sometimes anchor on your initial impression that keeps you from going to your critical thinking. That was the case in this child. This child was a 9-month-old, referred from an outside hospital because of leg pain. And this fracture, and I think you can see my cursor, I'm pointing it out to you, and hopefully you can see it. This was a pretty typical, what would be called a toddler's fracture, say if this were a 12 or 15-month-old running around or starting to walk. But in a 9-month-old, this is an unexpected injury. Notice I'm not saying possible or impossible. I think we all need to get out of thinking that way, because that's not helpful thinking. The thinking should be, do we expect this injury? Because that helps you get to is a reasonable suspicion. And because this was tagged as a toddler's fracture, abuse was not seriously considered. This injury was treated, and the child was sent home. I don't know if I have it on the slide, but interestingly, this child did have a previous sentinel injury. So here you can see the fracture a little bit close up. I hope you can see it there in that right image. And so this really safety was not found for this child. We'll just put it that way. And 1 month later in an orthopedic clinic, you can see it's healing. It's healing nicely, just as you would expect. But 6 months later, this child was murdered, suffocated by the mom's boyfriend. And I think this is a good case of anchoring, but also premature closure. And this child died. So another troubling situation is that I think, at least in medical settings, this needle in a haystack, this needle depicted here is much larger than any of us could see this needle. But the real needle is something that's buried somewhere in this haystack. And that is, if you see 100 accidental parietal skull fractures, how do you critically think and detect the 2% maybe that are, or whatever it is, that are due to abuse? And this is challenging, and especially when you think about the medical groupthink tends to be focused on treatment. We also can get lured into a sense of, well, there's an explanation, and it was a fall, and a fall actually is the most common cause of a parietal skull fracture, but it's also one of the most common false histories offered for intentional injury. So you can see, I think, the challenges in thinking here. So clinical decision rules, which are essentially kind of like algorithms or decision rules in place in a medical environment that help you stay the course and make sure that you're considering appropriately other possible diagnoses, and that you're doing appropriate screening, have been very helpful. And so Mary Clyde Pierce published one called the 10-4 rule, but there are multiple clinical decision rules for multiple medical conditions that help medical providers stay evidence-based. And so there are other strategies like peer review. Most child abuse pediatricians are very familiar with this concept. You all might be familiar with it in the context of forensic interviewing, but peer review helps keep us thinking critically together so that we can avoid the impact of those cognitive biases. And then education, but education alone, we know, is not sufficient to keep us out of trouble. So we should utilize systematic, evidence-based, and screening, I think, is even maybe the wrong word here. But in child abuse pediatrics for children under the age of 2, we utilize evidence-based screening for occult injury tools that are very important, and those should be used consistently, systematically, routinely when appropriate. And I think avoiding that discretion of, but this is a good family and we're not going to do it in this case, or I'm not going to report that because of I'm at the end of my shift, or I know this family, or whatever the biases are at work. So to routinely use and consistently use these when they're appropriate is really important. And then we love to look for mimics, and we do so routinely. So there is a kind of the standard child abuse medical evaluation for children under the age of 2. It's in your handout. I'm not going to go through it. That's not the purpose of today. I'm going to turn to the question pane right now and checking my time. I think we're okay. The question that I see here, is there bias in the other direction of seeing cases of abuse over and over again, and therefore finding abuse where there isn't any? I've wondered if my work makes me jaded and trying to balance all of it. I'm 32 years into a career focused on child abuse pediatrics, and I will tell you more so now, and I think this is true of my colleagues, I look harder for things that aren't abuse, because if anything, I have a strong disincentive to find abuse. And I maybe what you're suggesting is true. I think it's more true maybe for people who are very junior in the profession, might be more likely to slip into that, trying to justify their position or what have you in an organization. But I know many colleagues nationally, and I think if anything, most child abuse pediatricians, at least, I can't speak for child welfare professionals or law enforcement professionals, but we like it to be something other than abuse because it's easier. Many of the other causes are treatable. You can save lives if there's a medical intervention that could potentially help a child or a family. And I think all medical providers want accuracy in diagnosis. That is a core value of the medical profession. So I understand the question, but I don't think it is usually at play. And I don't think it is actually with my child welfare colleagues either, or law enforcement colleagues, but I can't speak for you. So what are the mitigation strategies, knowing that to err is human? There are actually a lot. One, I mean, this is a cartoon, but it's really not funny. But we almost need these kind of mile markers to say, stop and think. Check yourself with your colleagues. Create situations where people are free to speak up. Correct people when they use a toddler's fracture for an injury in a 9-month-old or a nursemaid's elbow for a 4-month-old. Because when you see something, you should say something, and it helps all of our systems improve if we use language to help us think more critically. And so again, I'll put in a plug of using the term sentinel injuries for these medically minor bruises and mouth injuries and the red spots in the white of the eye, which are subconjunctival hemorrhages, in young infants where it's an unexpected injury. And so using language to help us, but use your peers. And there are systemic strategies as well. So I think, again, kudos to a wise colleague who helped me organize this lecture. But there are both individual and systemic strategies that we should employ. The individual strategies are actually many. If any of you listened to the last weekend webinar, I think it was the last one, this icon will be familiar to you. Some very smart colleagues from Texas and Missouri created this Child Protector app. It's free. It's in your app store. And it helps you, particularly I would say for law enforcement and child welfare, but also for medical providers who don't have a lot of background in recognizing child maltreatment. It helps you with at least some initial guidance. And then I would say using this app and then knowing who to call. Who are your board certified child abuse pediatricians, or some communities have general pediatricians with extensive training and expertise in child maltreatment, but know who your experts are and feel free to reach out to them and give them the facts of your case, check your thinking, but avoid saying things that this is a nice family or some of that superfluous detail that has absolutely no relevance to making these determinations. In pediatrics, this is really hard. And I'm going to acknowledge that even for an old child abuse pediatrician like me, this is really hard because even to this day, I think people in general are good. And I'm a pediatrician. Usually the very best advocate for a child is a caregiver, often a parent. And so we are taught to believe the history provided to us about children we're caring for. And what I'm asking medical providers to do is at least be willing to flip that paradigm and at least consider that the information that we're hearing may not be accurate. And it's not always maliciously inaccurate. It can truly be that the person you're talking to has brought the child into you, may be unaware of some additional history, or may have been told something that's not correct by a spouse or other caregiver. So these are not all intentional attempts to deceive, but we have to be critical thinkers and hold each other accountable. So medical providers individually use a variety of strategies. Most of these are readily available, but going to them and putting proper weight on them can be a challenge. And so some of those are the clinical decision rules, or those decision algorithms I talked about, checklists, make sure you've thought about everything, order sets, where if child abuse is a concern, these are the things that you should be ordering medically. Note templates sometimes will help us guide our thinking and make sure we're not missing a key part of the medical history or the key part of the exam. But all of you can do this in your own professional settings. You just need to check your thinking and put into place some sort of culture that encourages disagreement. I'm going to quickly go through the next few slides because they're kind of medically oriented and most of our audience is not medical, but consider that you are at high risk of missing child abuse. And so making sure you stay curious, asking pertinent questions, always asking that question, is this injury expected given this history? Not, is this injury possible? That's the wrong thinking. That's a dichotomous thinking that puts you in danger of making significant cognitive errors. Do not ever suggest to a family or caregiver an explanation or timing or biomechanics, because you're setting yourself up and the family up for essentially contaminating the history, and we don't want to do that. We want to get the information in an iterative fashion with the various players who need to be at the table. Are the injuries expected? Is there asking about sentinel injuries is an easy strategy when you're dealing with some of these equivocal injuries in childhood. Or if you know there's domestic violence in the home, arming that mother with information that bruising is not expected in pre-cruising infants so that she's in a better position to seek care if she sees a bruise, but also to navigate safety for her children. Were occult injuries considered, and were they performed, screening performed? Do you have an opportunity to interview other children and other witnesses and examine those children? And developmentally, is the injury expected? So there are these various yellow and red flags you'll see, but on this particular one, this tendency to explain away an injury is rampant in the medical field. We've had cases, and by very good providers, I'll say that, very, very good providers, who suggested to a family that a subconjunctival hemorrhage or a red spot in the white of the eye was self-inflicted, even though that wasn't the history. And that child actually had retinal hemorrhages as well and had subdural hemorrhages and multiple findings from abusive head trauma, but initially sent away from a clinical setting because of that suggested history. We've had several children where the initial provider suggested to a family for a spiral fracture of the humerus, which is the upper arm bone, that maybe the baby got the arm caught in the slats of the crib, and that had never been the history, but then was picked up as a history in both of those cases and carried forward. And that was completely a suggested history. And then on the contrary, I had a case that will remain vivid in my memory where an African-American mother went to an outside hospital with her infant, and she was asked if she ever shook her baby. And she was offended, but said no, but then was referred into the tertiary care facility where she made a spontaneous statement to a care provider, to a medical provider, that she wouldn't shake her baby. And then that statement was then used against her as a reason for suspicion for that she might have shaken her baby because she voluntarily and spontaneously offered that. But when you peel back the layers of the onion, that was not what happened at all. So unintentional versus inflicted trauma, just keep in mind, do you expect this injury? And somebody who I knew and greatly respected, Dr. Rob Kirshner, who is a forensic pathologist but also a human rights activist, published this kind of dirty dozen years ago. And it's not to say that any of these would indicate abuse. They don't, but they all indicate reason to very seriously in some of the cases, but at least consider in all of the cases, consider abuse. And so that's how he meant this. And I've loved this dirty dozen plus, and I've added a few to it, which a few are here. But one individual strategy you can have is if you get that feeling in your gut that something's amiss here, I don't expect that injury, or something's not adding up, pay attention to that unsettling, that gut feeling, because that's probably when you need to be checking your critical thinking. So I'm pausing for questions, seeing none. I'm going to go on. And there are a few systemic and work environment strategies that I hope you will find very helpful in mitigating against the impact of biases, because you're not going to eliminate them, but you can mitigate against their impact. And these are, I've been mentioning some of them, but use your colleagues. Give them just the facts. In medicine, I want just the history. I want to know what the injury is, and then let me ask if I need additional information. But if the history doesn't make sense with the injury that is being seen and documented, further exploration is indicated, and usually further workup and often reports. Get your team, whatever your team is, whether it's sensitive crimes or whether it's your unit in child welfare, or whether it's your division or section in a medical setting or your team in a medical setting. Start to help turn the culture so you have this wonderful devil's advocate culture where anybody, even the first-year med student who just joined your rotation today, can bring up, could this be something else? And make it safe for that person to do that. That culture of curiosity, that culture of peer review. You want to break down hierarchy, because hierarchy, if people are intimidated by the attending or intimidated by the culture that has developed within a unit, they're not going to feel safe to bring up alternative explanations. Use your peers outside of your profession. I think that's where a multidisciplinary team can be invaluable. I think All of us owe it to each other to have challenges and multidisciplinary team discussions about what else could this be? Have you considered? I need this additional information, because at the end of the day, working collaborative in that fashion and trusting each other, we get to better accuracy. Medical, my team uses peer review. It's part of the culture of child abuse pediatrics. Law enforcement and CPS, I would encourage you that when you have an explanation by a caregiver that maybe wasn't offered initially, don't just ask about the explanation and then say, oh, okay, we now have the explanation. Say, and then what? Because what you want to know and what your medical provider is going to want to know is, does that make sense in terms of the child's symptoms? So what happened after this accident, this fall, this whatever, to explore whether or not that makes medical sense, and listen to each other. You want to reward this culture. You want to, hopefully your leader will acknowledge and thank people for bringing up alternative hypotheses. You want to build a culture that's safe for all of us to talk about something else that this could be. The hierarchy is toxic. When people quit feeling quite so confident in themselves and step back and listen, and maybe even amplify the quiet voices in your group, you will have a much richer team and better decision making. And then, of course, you always want to ask questions to better understand and remain curious. As I referred to before, this profession is challenging. You want things to be yes or no. Is this abuse? Is this not abuse? But many of the cases we deal with have shades of gray. We have to know that we're going to manage ambiguity, and we have to help each other manage this and make the best decisions possible based on the information that we have and can have. Keep in mind, at least on a medical side, that even if you do the entire child abuse workup and you don't find any other injury other than that sentinel injury, that you haven't ruled out abuse. Sometimes that bruise is the first injury from abuse, and you hopefully have ruled out a bleeding disorder as best as you can. A significant percentage of cases referred to our team, we ultimately determined to be a low or no suspicion for abuse. And that kind of goes to that bias question that came up earlier. We like these cases. We all must have a strategy for coping with ambiguity, and our teamwork together will always lead to better and more accurate decisions. So I have the key takeaways on this slide that I'm not going to just read to you. I think if this topic of medical errors interests you, this actually extends well beyond medicine. This extends into the business world and many other disciplines. But I particularly have enjoyed the writings of Pat Croskery because it's helped me think about how to find accuracy and minimizing the impact of cognitive biases on decision making. So there are a few references here. I was required to put them at the end, but there are also various references throughout, and these are selected references even throughout the talk. There are many other references that I've used in putting this talk together. So I'm looking at the question pane. I'm going to pause a moment. We're at 1 o'clock. I'm going to put up your CME slide or your CE slide, and I'm going to thank you. I think this topic is a really hard topic for all of us because it forces you toward introspection, and I thank you very much for attending and hopefully listening carefully, and for the teamwork that all of you provide every day.
Thank you, Dr. Sheets. I'll ask you to leave the attendance slide on the screen for a couple minutes. Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar, Combing Through the Evidence, Pros and Cons of Hair Drug Testing, presented by Dr. Hilary Petska. Thank you for being with us today.